Hello friends, I am Dr. Vijay Prakash and today I'll be speaking to you about balanced occlusion. Now before we go into balanced occlusion, we should know what is occlusion in complete dentures. Occlusion simply means a contact between the occlusal surface in both the static and functional movements. And these contacts have definite role in stability of the complete dentures. It enhances the comfort of the patient, the chewing efficiency, and increases the aesthetics of the denture. Now, by definition, if we see what is occlusion, occlusion is the static relationship between the incising or the masticating surface of the maxillary and mandibular teeth or tooth analogues. Now, there is another similar terms, that is articulation. What do you mean by articulation? Articulation is defined as a static and dynamic contact relationship between the occlusal surface of the teeth during function. And balanced articulation is a continuous sliding contact of the upper and lower cusp all around the dental arches during all close grinding movements of the mandible. So this is the definition part. Now let us know the difference between the natural occlusion and the artificial occlusion. So if we talk about the natural occlusion, that we find that the natural teeth are independent of each other. You can see that they are independent of each other, and non-vertical forces are well tolerated and affect only the tooth that are involved. That is because of their simple reason, because the roots are housed in an individual socket. So incising with the anterior teeth will not affect the posterior teeth, unlike in the dentures. If the patient is incising from the anterior teeth, it destabilizes the denture. Second molar is the favored area in a natural dentition. If we see, this is the more favored area for chewing, and bilateral balance is not necessary. So either a canine guided occlusion or group function works very well in the natural teeth. Malocclusion can be eventful for a long time, whereas there is no question of malocclusion in an artificial occlusion. And proprioceptive impulses give a feedback mechanisms which is not there in the artificial dentition. Also, the natural teeth are retained by the periodontal ligament, which are uniquely innervated and structured. Whereas if we see in an artificial occlusion, all the teeth act as a unit. See, all these teeth are attached as a unit, and the occlusal load is dispersed over the entire unit. The lateral or non-vertical forces will affect the stability of the processes. Also, if the patient is biting from the incisors, there will be destability of the posterior bases. Bilateral balance of the denture or balanced occlusion in the complete denture is necessary for increasing the stability of the dentures, and malocclusion poses immediate problems involving the teeth and the base. The denture base rests on a moist and slippery tissues, so definitely stability and retention is one of the issues. So what is balanced occlusion? By definition, balanced occlusion is defined as the bilateral, simultaneous anterior and posterior occlusal contact of teeth in both eccentric and centric positions. Now, what are the goals of balanced occlusion? One is you have to have a maximal bilateral simultaneous contact on either side. Also, the working side, if we see, the contact has to be, so on the working side, that is the position of the jaw to which side it moves. So on this case, it is this side, that is the right side. This is the working side, and here we see that there is working contacts are present all along the working side from the canine to the posteriors, and balancing contacts, that is the non-working contact or balancing contact, are there in the protrusive also, and in the lateral movements also, as you can see here also. So in protrusive position, if we see, as the patient brings the jaw edge to edge forward, and there is at least 3-point contact in the posterior region. So this is in the protrusion, and the occlusal plane of the completed set are parallel to the maxillary and mandibular residual ridges. So now, what are the requirements for balanced occlusion? In balanced occlusion, all the teeth of the working side, that is from the canine to the second molars, should glide evenly against the opposing teeth. Like we see here, they should glide evenly against the opposing teeth, and all the teeth should be having this kind of relationship. There should be a smooth glide. They should not interfere in between. There should not be any kind of premature contact which destabilizes or makes the dentures unstable. No single tooth should produce any interference or dislocation. Any interference anywhere on the working side or on the balancing side is going to destabilize, and you will not be able to achieve balancing. So there should be contact in the balancing side, and there should be a smooth contact. So as the jaw is moved towards the working side, there should be a smooth gliding contact. There should be a smooth contact here, as well as there should be a smooth contact on the non-working or balancing side. So when we talk about the protrusive contact, there should be a simultaneous contact on both the right and the lateral posterior teeth. So whenever the teeth are moved into protrusion, so there should be even contact, whether it is on the right side or on the left side. So what are the advantages of having a balanced occlusion? One, it stabilizes the dentures because there is no factor, because there is simultaneous contact in the centric as well as in all the eccentric positions. So definitely stability of the denture is enhanced, and bilateral balanced occlusion, they provide contact during the terminal arc of closure and helps in seating of the dentures. So whether you are making a protrusive movements or lateral movements, or whether the patient is biting in centric occlusion or maximum intercuspal position, so in all these positions you have a stable contact, the bases are stable, and you have an enhanced stability of the processes. Another thing is balanced occlusion helps in swallowing, as it allows even bilateral contact. Also, it helps in preventing the destructive lateral forces generated during any kind of parafunctional habits, and as I told you, it improves the stability, retention, and comfort of the patient. Comfort, why? Because as soon as the patient realizes that he is having good contact with the teeth, so he has a definite better comfort with the processes. And also the dentures which are not balanced tend to move during function, so that movement is eliminated when you are giving a balanced occlusion, shifting or movement, which you can say. Now what are the factors? Now what are the factors which affect or which helps in achieving the balanced occlusion? First, the factors of protrusive balance. One is the inclination of the condylar path, the angle of incisal guidance chosen for the patient. Third is the inclination of the plane of occlusion. Fourth is the compensating curves chosen for orientation with the condylar path. And fifth is the cuspal height and inclination of the posterior teeth. Now, let us see each of these factors one by one. Apart from this, the factors for lateral balance also I'll tell. Inclination of the condylar path on the non-working side, inclination of the incisal guidance and the cuspid lift, inclination of the plane of occlusion on the balancing or non-working side, compensating curve on the balancing as well as on the working side, the buccal cusp height or inclination of teeth on the balancing side, lingual cusp height or inclination of teeth on the working side, and the Bennett side shift of the working side. Now let us see all these factors one by one. One is the condylar inclination. Now, if we see condylar inclination, this is the only factor which is given by the patient. So you see, this is the condyles, and this is how the condyles move along the surface of the glenoid fossa. So it is the only factor which is given by the patient. The inclination of the condylar path, and this movement from along this path is known as the condylar path, is determined by the protrusive record. So we have to take a protrusive record, and the glide how it happens in the along this condylar path, you can have that record when you are taking a protrusion. You are taking a protrusive record. So this factor is fixed by the patient, and the clinician or the dentist cannot alter this. The articulator is programmed using the protrusive record of the patient. So once the patient has given you the protrusive record, you have to program that in the articulator according to the record which is given by the patient, and accordingly the occlusion of the articulator should be set. So once you have taken this protrusive record, you are going to position that in between the rims, and you will place it on the articulator. You loosen all these condylar locks, the centric locks, and you will raise the incisal pin and accordingly rotate them so that these rims accurately fit into a particular position. So that is going to give you the horizontal condylar inclination, and accordingly you can calculate the lateral condylar inclination by using the formula L is equal to h by 8 plus 12. That is the Hanau's formula. So by doing this, you have to program the articulator because you have achieved the horizontal condylar inclination as well as the lateral condylar inclination. Once you have achieved that, then you can go ahead with the arrangement of the teeth. Now next factor is the incisal guidance. It is also called the second factor of occlusion, or it is the terminal factor along with the condylar inclination. So this factor is determined by the dentist, and it can be altered depending on a particular individual or depending on that individual requirement. So it can be set depending on the desired overjet. This is the overjet, and overbite, that is the vertical overlap, so which is planned for the patient. So it is the anterior controlling factor. Now if we see, if the overjet is increased, so if you move the distance, this overjet is increased, the inclination of the incisal guidance is also is decreased. So as you move away from here, this angle is going to be lesser and lesser. So accordingly it will be lesser here. Also, if the overbite is increased, if I increase this vertical overlap, the inclination of the incisal guidance will be increased. So this angle is going to be more steeper. Now if we see, the incisal guidance has greater influence on the posterior teeth than the condylar guidance. This is for a very simple reason, because posterior teeth are more closer in action to the incisal inclination than the action of the condylar guidance. So if we are adjusting the posterior teeth, they are more closer to the incisors rather than to the condylar inclination. So that is the reason they have the greater influence in posterior teeth. So when the patient is making the protrusive movement, that is bringing the jaw edge to edge, the incisal edges of the mandibular anterior teeth, they will move first downwards and in a forward path corresponding to the palatal surface of the upper incisor. So this movement in relation to the palatal surface of the upper incisor is known as the protrusive incisal path or the incisal guidance, and the angle found by this protrusive path to the horizontal plane, that is this angle, is known as the incisal guide angle. This is the incisal guide angle, and this same angle has to be transferred onto the articulator. Accordingly, you are going to reposition the guide table so that you have the same angle, which is the incisal guide angle. So this factor is going to influence the shape of the posterior teeth. And if the incisal guidance is steep, the compensating curve is needed to produce the balanced occlusion. So in the complete denture, if we see, the incisal guide angle should be as flat as possible. That is, this angle should be as less as possible, because then only you'll have a good aesthetics, and also it will be comfortable to the patient. So if the incisal guidance is steep, and if this angle is very steep, then to achieve a balanced occlusion, you will require a very steeper cusp. So that will be having a high inclination. You will have steeper cusp, and steep occlusal plane or the compensatory curve will also be steep. So if this angle is more, you will have steeper inclination of the teeth. That is, and also the compensating curve where the teeth are arranged, that will also be very steep. And the location of the incisors is governed by the various factors such as aesthetics, function, and phonetics. So all these factors also govern the location where the incisors should be placed. Now next factor is plane of orientation. Now plane of orientation should be established exactly as it was in the natural teeth. That is, you are going to position the teeth where they were in the natural position, where they were before extraction. So it is established anteriorly by the height of the lower canine. So once you have placed the lower canine, accordingly you are going to place the posterior teeth. Also on the retromolar area in the cast, you are going to mark the anterior 2/3 of the retromolar pad, and you will draw one line that should be parallel, and all your incisal and the occlusal tips should be contacting with that. So that is the height of the occlusal plane. So it is essentially parallel to the elatragus line or the camphus line, and it can be slightly altered, and its role is not as important as the other factors. So this can vary. It can be altered slightly, it can be higher up or slightly lower. So tilting the plane of occlusion beyond 10 degrees you should avoid. And research shows that when the occlusal plane is parallel to the elatragus line, the closing forces during the maximum clenching is greater than when it is altered by 5 degrees or more. So definitely the patient experiences a good chewing force, and he feels comfortable better when you are arranging the teeth parallel to the elatragus line and you are not altering the plane of orientation or plane of occlusion too much. That it should not be altered, definitely not beyond 10 degrees. So next factor is the cuspal inclination. Now the teeth which we are using in balanced occlusion can be anatomic teeth, can be semi-anatomic teeth, or non-anatomic teeth. So if you are having anatomic teeth, the cuspal angle is around 33 degrees. If you are using semi-anatomic teeth, it is around 20 degrees. And if you are using non-anatomic teeth, it is 0 degree teeth. That is, it is flat, it is horizontal. So cusp on the teeth or inclination of the cuspless teeth, that is the non-anatomic teeth, are important factors that modify the effect of the plane of occlusion and the compensating curve. The mesiodistal cusp lock the occlusion such that repositioning of teeth does not occur due to settling of the base. So this is another important factor. In order to prevent the locking of the occlusion, all mesiodistal cusp are eliminated during occlusal reshaping. So the mesiodistal aspect. So the commonly used posterior teeth are having cuspal inclination, as I mentioned to you. It is 33 degrees as in the anatomic teeth, 20 degrees semi-anatomic teeth, and 0 degree for non-anatomic teeth. Although the effective final height of the cusp depends on the inclination of the teeth, how you are inclining these teeth when you are arranging the teeth will actually be more determinant than the cuspal inclination as such. Incisal guidance, condylar guidance, height of the occlusal plane, and compensating curve. So 33-degree posterior teeth are best suited for balanced occlusion. So in order to achieve balanced occlusion in non-anatomic teeth, you have to alter the positioning, how you're positioning the teeth along the compensating curve. So that will give you the balancing in non-anatomic teeth. Next is the compensating curve. So compensating curve is determined by the inclination of the posterior teeth, how they are inclined, and the vertical relationship to the occlusal plane, and how they are oriented in relation to the occlusal plane. So if you have a steeper condylar path, it requires a steeper compensating curve, as I mentioned in the occlusal plane also, and in the incisal guidance. If you have steeper condylar path, if the condylar path is very steep, then you need to have a steeper compensating curve in order to compensate for that steepness. So it will require steeper compensating curve that will then balance the occlusion. So that factor anyhow we are not having in control. So what factor you can alter is the incisal guidance. You make it as flatter as possible if it is possible. Now compensating curves can be of two types. They can be anterior posterior curves, which is curve of Spee, as you can see in this figure, and you have the lateral curves, which is curve of Wilson, curve of Monson, and the pleasure curve. So this topic anyhow, compensating curve, I will discuss some other time. So these are all the 5 factors which are very important for balanced occlusion, which I just discussed. Next is, what are concepts of balanced occlusion? Now different authors have given a different concepts in attaining the balanced occlusion. Now let us see some of these interesting concepts. One was given by Alfred Gysi in 1914, in which he used 33 degrees cuspal forms, and so he suggested that 33 degrees anatomic teeth, they can be arranged under various movements of the articulator, and they will enhance the stability of the dentures. So in lateral movements, cusp contact bilaterally to increase the stability. In centric occlusion, the forces are directed towards the ridges. As you can see, the forces will be directed towards the ridges in centric occlusion, and in lateral position, the occlusal contacts are directed away from the ridges. So when the patient is moving the jaw away, that is in the lateral, right lateral or left lateral position, so in the lateral position, if we see, the forces, the contact forces are directed away from the ridges, as you can appreciate here. Next concept is the French concept. Now he used the modified French teeth to obtain the balanced occlusion, and what he suggested was lowering of the lower occlusal plane in order to enhance the stability of the dentures along the balanced occlusion. So he arranged the upper first premolars having lingual occlusal inclination at 5-degree angulation, upper second premolars with 10-degree angulation, and upper molars with 15-degree angulation. This is how he inclined the lower posterior teeth. So premolars with 5 degrees, first premolar, second premolar with 10 degrees, and the upper molars with 15-degree angulation. So that what he wanted to achieve was balanced occlusion can be achieved laterally as well as anterior posteriorly by arrangement of these teeth on the curved occlusal plane. So actually he gave a curved occlusal plane, and he wanted to enhance and achieve balanced occlusion by having these contacts, by inclining the teeth into various inclination. He wanted to achieve balanced occlusion. That was the French concept. Next concept is the Sears concept, which was given in 1949, and he introduced the balanced occlusion for non-anatomic teeth or 0-degree teeth, that is the flat teeth, using posterior balancing ramps or occlusal plane which curves anterior posteriorly and laterally. That is how you can achieve balanced occlusion in non-anatomic teeth by inclining the positioning of the teeth, which can be anterior posteriorly and laterally. So if you see in centric occlusion, the contact forces are directed towards the ridges. They are directed towards the ridges, and in lateral position on working side, they are directed towards the ridges, and on the balancing side towards the buccal side of the ridge. So here if we see on the lateral side, they are directed towards the ridges, but on the non-working side or the balancing side, they are directed towards the buccal side of the ridges. Next is the pleasure concept, which was given by Max Pleasure in 1937, and he introduced basically this concept to align and arrange the posterior teeth in order to increase the stability of the prosthesis. So he used a reverse curve in the first premolar, flat occlusal surface in the first premolar. You use the reverse curve in the flat occlusal plane on the first molar, and a Monson curve on the second molar was used in order to achieve balanced occlusion. So the reverse curve helped in directing the forces of occlusion lingually to enhance the stability of the lower denture. So in centric occlusion, the forces are directed towards the ridges, and if you see the right lateral position, the forces are directed towards the lingual side of the lower ridge on the working side. So that is how he gave this concept in order to achieve balanced occlusion. Next factor is Hanau's quint, given by Rudolf L. Hanau in 1929. He proposed 5 factors which we have already discussed in the factors which were very important in achieving the balanced occlusion. They are the same as condylar guidance, incisal guidance, compensating curves, relative cusp height, and the plane of orientation of the occlusal plane. So I am not going into detail of this because we have already discussed in the factors. Next concept is the Trapozzano's triad of occlusion. Now he called it triad of occlusion. Why? Because when he reviewed the Hanau's quint, he came to a conclusion that only 3 factors were important to achieve the balanced occlusion. So what he eliminated was the plane of occlusion, as he believed that its location is highly variable. It may be higher up or lower up, and it depends on the availability of the interarch space, because that's how the plane of occlusion can vary. So he suggested that occlusal plane should be located at various heights to favor the weaker ridges. The other factor which he considered unimportant was the compensating curve. So when the cuspal inclination that will produce the balanced occlusion is determined, the concavity or convexity of the curve can easily be evaluated. That was his concept. So according to him, only the incisal guidance, the condylar guidance, and the cuspal angulation are the 3 factors which he considered were important in achieving the balanced occlusion. Next factor is the Lott's concept, which was given by F. Lott, and he studied the Hanau's work, and he clarified that laws of occlusion by relating them to the posterior separation is the resultant of the guiding factors. So according to him, what are Lott's laws of occlusion? One is the greater the angle of condylar path, greater the angle of this condylar path, greater will be the posterior separation. That's how this posterior separation will be there during protrusive movement, as the patient is bringing the jaw forward in protrusion. Greater the vertical overlap, greater is the separation in the anterior region and the posterior region, regardless of the angle of the condylar path. So once the teeth are moved, when there is a greater vertical overlap, and this is simply the incisal guidance factor. So if you are increasing or decreasing the vertical overlap, you are basically altering the separation in the anterior region and the posterior region. Next is the greater the separation of the posterior teeth, greater or higher will be the compensating curve. That is, this factor is also coming into picture. Another thing is posterior separation beyond the balancing ability of the compensating curve requires the introduction of the plane of orientation. So plane of orientation is very much required if we are going beyond the range of the compensating curve, that is the posterior separation. So greater the separation of the teeth, greater must be the height of the cusp in the posterior teeth, because higher then will be the angle of the condylar inclination. So all these factors are relative, and this is the Lott's laws of occlusion. Now next concept is the Levin's concept. So in this concept, Levin basically gave a similar concept to Lott's concept, except where the plane of orientation factor is eliminated. According to him, the plane of occlusion can be slightly altered by 1 to 2 millimeters in order to achieve or improve the stability of the denture, and he named other 4 factors as chord factors. Like you can see, these are the guiding factors: condylar inclination, incisal guidance, and the controlling factors are the compensating curves and the cuspal heights. So these 4 factors are called the chord. Now the condylar guidance is fixed and it is given by the patient. We have already discussed this. The balancing condylar guidance includes the Bennett shift of the working condyle. This may or may not affect the lateral balance. Second thing is the incisal guidance is obtained from the patient's aesthetics and phonetic requirements and can be varied by the dentist. However, it can be modified. Compensating curve is the most important factor for obtaining balance. Monoplane or low cusp teeth should employ the use of compensating curve, because in order to achieve balanced occlusion, that is the only way how in non-anatomic teeth or 0-degree teeth you can achieve balanced occlusion, by altering the angulation of the teeth. So cusp teeth or anatomic teeth have the inclines necessary for obtaining the balanced occlusion and is one of the most favored teeth for achieving balanced occlusion, but are used mostly with the compensating curve. So cusp teeth should also be used along with the compensating curve. That was according to Levin's. So these are some of the concepts which are there in the balanced occlusion. So now let us see what is the importance of balanced occlusion. Now, concept of balanced occlusion was initially put forward to increase the retention and stability of the complete dentures during mastication. But as you must have heard that Shepard very rightly said, enter bolus, exit balance. That was that even a small food particle on the working side can eliminate the balance on the non-working side. That was he argued in 1968. So that was one controversy. I will not say controversy, but another thought process which was against the balanced occlusion. So there were many researchers who defended that balanced occlusion is very much necessary for complete dentures, like Brewer and Hudson. They showed that complete dentures do not contact at all times during mastication. There are only 17 minutes in a day that there is actually contact between the upper and the lower teeth. So balance occlusion is necessary during the other excursive movements such as swallowing, saliva, closing to reseat the dentures, bruxism sometimes, which is performed by the patient during chewing of food. So hence, if balance occlusion is not present, the bases can displace and they can tip or torque on the foundation, which can result into causing inflammation on the ridges and which may enhance the bone resorption. So it is always said that complete denture balanced occlusion should be given, and equal contact of all posterior teeth in centric relation is very much essential for maintaining the health of the mucosa. Therefore, it is widely accepted that balanced occlusion for complete denture is ideal type of occlusion which should be given to the patient which will not only increase the stability of the processes, also the comfort and the chewing efficiency. So with this we come to end of our topic. Thank you for listening.